Together with my co-chair, I would like to thank Professor Thornburn, but we need now to move on. We have a little less time for discussion of the session, Progress in the Treatment Landscape. But together with John, Chris, and Jane, we would like to start the discussion. And there are questions from online, which were from yesterday, which I would like to address now, actually. And that was about patients who have undergone renal transplants. So usually these patients are, not possible for them to enter clinical trials. But what about treatment, surgery, or systemic treatment? Because we have a panel of doctors now. So what about patients with renal transplants? What are the options or the disadvantages for them? Who wants to start? John.
So I don't see any difficulties with renal transplant patients going into study. The primary issue would be around the use of immunotherapy. Can't do that, essentially. There's about a 50% kidney rejection rate if you do that. And so we've stopped. I think a few people received it in the United States a while back, and nobody's dared do it since. That's about it, though. In every other way, I think they should be eligible for study and or treatment.
Clear answer. So only the immunotherapy is a threshold here. How about a surgery? Anyone who would like to say anything about it?
Well, no personal experience, but I suppose you're already looking at challenging surgery with a more challenging patient, and perioperatively, their morbidity rate, you've already seen an overall complication rate of 75%, and you bring in then the complications of the renal transplant. I think you have to be realistic with the patient that it's going to be a tough journey ahead for them, both with either surgery or chemotherapy, but it's not a preclusion to treating them if there's fit enough to come through the anaesthetic assessment. And
thanks for addressing this. So we have a question here in the audience on microphone on the left.
Yes, thank you very much. My name is Freek Brands. I'm from the Amsterdam University Hospital. Very interesting presentations. I have a question for Professor Bridgewater about targeted therapy. In my clinical experience with targeting therapies entering the market more and more, say for instance the FGFR blockers, do you have any experience in, say for instance the patient is on an FGFR blocker and then has progression disease? Do you switch to other FGFR blockers? Do you have any experience in that?
Yep, so there are several things you can try and do. The first is to see why your patient has become resistant, the way to do that is with sequential liquid biopsies. So we know that in about half of these patients it's because of the development of new subclones, new alterations, primarily in the mutations in the FGFR2 gene, and based on that you can determine whether another FGFR drug will be helpful or not. So that's quite a useful thing to do. There are new trials coming along with new drugs that essentially don't worry about any of those mutations and would hopefully be effective. And of course we also have a study. We have the first 308 study which uses tinangotinib, which is a drug specifically designed for FGFR2 resistance. So it's not a perfect situation, but there are some options.
Thank you.
We have another question from the floor.
Maggie Bastendine, Newcastle Emeritus. In the past decade, there's been wonderful advances in some areas, particularly in the, it's very encouraging to be here and see these advances, particularly in the directions of targeted therapy. But we've known for 2 or 3, if not 4 decades, that cholangiocarcinoma is vastly increasing. When I qualified, it was as rare as hen's teeth, and now we've got presentations from younger people who are dying of it under the age of 50. So there's 2 questions I'd like to ask. One is whether any of these mutations are known to be directly linked to any potential known carcinogens? And the other question I'd like to ask is there a unified way that's going on in the UK to collect, or worldwide, hopefully, to collect samples so that we can look for the toxicological things that are going on that are causing this increase? Because it's all very well to have improvements in treatment, but we can't keep up with the increase. I mean, it's just ridiculous that we've got people dying in their 30s of cholangiocarcinoma, and that would be unheard of when I qualified in medicine. So I don't know what's going on in that, because I'm a bit out of the circuit because I'm retired. So that's my question.
John, would you like to take that?
Yes, thank you for that. It all comes down to the etiology.
Yes.
The etiology, and it's slightly different for each type of cholangio. So the etiology of intrahepatic cholangiosis is actually very similar to the etiology of hepatocellular cancer, which is liver damage. And so the increase in cholangio, particularly in young women, is related to something that's happening in the liver, be it primary sclerosing cholangitis, be it liver damage, be it cirrhosis, be it other things that hit the liver, we think.
Well, I disagree with you there, because all those things hit the liver ages ago. But now we've got new environmental factors that are having a... sorry to disagree with an eminent professor.
Well, I disagree. Please disagree as much as you like. There's probably something new that we're doing to our livers that we don't know about.
Yeah.
Is what you're saying,
Yes.
and I'm sure that's right. I'm sure that's
So
something.
we really ought to be looking at at more of the toxicology. I mean, my partner died of non-smoking related adenocarcinoma, and we've known for years that cadmium is a carcinogen. Nobody measures cadmium in anything. You know, why aren't we looking at a class 1 carcinogen in some of these adenocarcinomas? So that's, anyway, I'll go and sit down before I get agitated.
No, actually, I'm very pleased that you asked this question. This was one of the questions I had on my list if you wouldn't have asked it. But it's a difficult one, because the only thing I can suggest, and I'm looking at Chris maybe, so the question, of course, you raised is, do we do like a blood sample or a tissue sample to test for whatever toxins we have to digest because of what we eat or what's in the environment, in whatever new cars, what we have to, there's everything everywhere, and we cannot even sometimes measure it, so that's why toxicology is so important. So are we aware of any study who is doing, during the process of diagnosis, anything on that subject? Are we aware of any study?
Yeah, it's outside my area of expertise. I'm a jobbing plumber, but over the years, there's certainly been epidemiological studies, and Shahid sort of, as part of his initial PhD, sort of pioneered some of those studies, and there have been environmental toxins that have been implicated, and thorotrast was an X-ray contrast that was implicated. I think that there were some byproducts of rubber production in the old days that were implicated, but these are historical factors, and they certainly don't explain, increased frequency in people in their 30s and 40s now. So I'm not aware of any research that's going on in direct looking at bile toxins or other environmental toxins experimentally, but as I say, it's not my area of expertise.
So I guess we will have to wait until no new progress. So John, you want to add?
No, I've got a question for him.
Okay.
As part of your life-saving plumbing, you put in uncovered metal stents into patients. So now we're in a situation where I have 3+ patients with uncovered metal stents in place who've been found to have mismatch repair deficiency, who are likely to be long-term free of disease. What happens? They just stay there? Are there any? Do we know what happens to metal stents? You leave them there forever?
We do, because we sadly have very small cohort of patients who've had bare metal stents placed for benign disease, and we've got a slightly bigger cohort of patients who had bare metal stents placed for metastatic breast cancer and for lymphoma. sort of deliberately for breast cancer years ago and inadvertently for lymphoma, because that would have been avoided for many years now. And they do often run into trouble. It often seems it takes a long time. Often it's sort of 6-7 years before you run into big trouble. But we've got a small cohort of patients we follow up, none of whom we stented ourselves, who we're regularly going into using RFA dilatation, using removable stents to try and recanalize blocked biliary stents. And I think it's something that we need to be alert to, is that if we're going to start achieving really much better outcomes with the newer drugs, is being very, very thoughtful about the use of bare metal stents. But the flip of that, of course, is that, as I alluded to in my talk, if we revert to using plastic stents, changing them every 2 to 3 months, the implications for the majority of patients undergoing chemotherapy treatments in terms of disrupting their treatment, multiple admissions, multiple exposure to potential complications, I think it's going to be quite a complex discussion, but it's probably one we need to start having. I mean, your HPB colleagues, HPB medicine colleagues at UCLH have access to the sort of same technological stuff we do, but there are no great tricks for unblocking and certainly not removing these stents. It is virtually impossible to shift a bare metal stent after years of placement.
Sorry, we're going to quickly just get this one lady, because we've just got a few seconds before we go to the tea break.
Sorry.
Please, a short answer, please.
I'll keep it short. Just back onto the point of environmental, Besma Grief, oncologist from Nottingham. Just on the point of environmental factors, which I think is a really interesting thing, especially with the increased incidence. I believe there is some work going on in Cambridge and other malignancies where they're doing some genomic work, where they're actually able to identify toxin exposure just based on the pattern of mutations. So I think this maybe could be an interesting thing. My main question, though, sorry, I'm going to get told off. John, how are you routinely offering liquid biopsies to your NHS patients, or are they self-funding, and how much does that cost? And do you think it's something that we should be discussing with patients?
Yep. So outside of study, liquid biopsies are not funded. They cost about 1,800 quid. And they can be incredibly useful, but in very specific circumstances. Not routinely, absolutely not routinely.
Okay, well, thank you very much to our panel, Jane McClements, Chris Wadsworth, and Professor John Bridgewater, and obviously Professor Thorburn online for a really interesting discussion. We're going to break for the last tea break of the day before we begin the final session of the day, which is going to be looking at the international aspects of cholangiocarcinoma. So we are back at 3:55. Thank you.